Hey everybody, today we've got another specimen. This is number 425 in our collection, and the heart would have sat in the chest like this. Anterior surface here towards the camera, posterior surface towards the turntable, left over here, right over here, head or superior up here, and then inferior down here. You can see that the trachea is still attached, and both the left and right lungs are still connected to this heart. Let's start off where we usually start off, which is by finding what appears to be the right atrial appendage, at least externally. And here we have a appendage that's pyramidal in shape, triangular or broad-based, which is consistent with a morphologic right atrium. So let's go ahead and open this up. And when we do that, we do find that there are pectinate muscles that spill outside the confines of the appendage, which is consistent with the morphologic right atrium. When we take a look at this right atrium, we do see that there is a deficiency in the oval window here. So there is an oval window type atrial septal defect. And we see where the superior cable vein would have entered the right atrium. Now, when we turn our attention back inside the right atrium, we do also find the coronary sinus right here. And remember, the coronary sinus is an important structure as it does bound the triangle of Koch, which is the coronary sinus, the tendon of Totaro, and the septal leaflet of the tricuspid valve. And this is an important structure because at the apex of this triangle is where we would expect the atrioventricular node to live. So once again, the triangle of Koch bounded by the coronary sinus, the tendon of Totaro, and the septal leaflet of the tricuspid valve, and at the apex of this triangle is where we expect the atrioventricular or AV node to sit, so an important structure electrically. When we take a look at this AV valve on the right here, we do find that there are 3 leaflets, and that it leads to a ventricle that does have coarse trabeculations and a septomarginal trabeculation, all consistent with the morphologic right ventricle. Now, when we look at this ventricle, we do find that there is an outlet type ventricular septal defect here. It's an outlet ventricular septal defect as it does live within the Y of the septal band, or phrased differently, between the cranial and the caudal limbs of the septomarginal trabeculation. So you can see this Y here, and within that Y is where this ventricular septal defect lives. And it's important to note what the borders of this defect are. Obviously, superiorly, it appears to be a fibrous border because of the valve leaflets. And then postero-inferiorly, it does appear to have a muscular border. But more interestingly, as we look at this outflow tract here, we see an arterial trunk that arises, which gives rise to coronary arteries, the ascending aorta here, as well as the pulmonary arteries. So this, in fact, appears to be a common atrial trunk. And remember, the definition of a common atrial trunk is whenever you have a single outlet from the heart, a single arterial trunk that gives rise to the coronary arteries, the ascending aorta, and the branch pulmonary arteries. This is different from pulmonary atresia with VSD in the sense that in that setting, the pulmonary arteries arise extrapericardially. So here we do have a pretty dysplastic valve that seems to be guarding the common arterial trunk. There appears to be 1 leaflet here, 2 leaflets here, 3. So it appears to be a 3 leaflet, 3 sinus common arterial valve or truncal valve. And once again, you can see that these are pretty dysplastic, thickened, rolled edges, and the common arterial trunk gives rise to the coronary arteries, which are here and here. All right. So now let's focus on some of the structures that arise from the common arterial trunk. Here is the ascending aorta that arises from the common arterial trunk. You can see we can pass our probe through this. And as we follow this aorta around, we can see that there's pretty significant narrowing of the transverse aorta here. So this is what we would end up classifying as a pulmonary dominant common arterial trunk. If we go back into the common arterial trunk, we can see the left pulmonary artery that arises from the left side of the common arterial trunk. And then if we look, we can find the right pulmonary artery right here. So left pulmonary artery, right pulmonary artery, and they both have separate orifices from the posterior aspect of the common arterial trunk. Once again, here is the left PA, and then here is the right branch pulmonary artery. And then anterior to this is another structure that arises from the common arterial trunk, and this is in fact the arterial duct, which was supplying the distal or descending aorta here. So here now we can really see the aortic arch come together, and try to line this all up. There we go. Ascending aorta, head and neck vessels. Then you see a pretty hypoplastic transverse arch, descending aorta that's of good caliber, and the arterial duct that is feeding the distal transverse arch and descending aorta. Now, if we were to turn this heart to its back to look at the posterior aspect of the heart, you can go ahead and open up what appears to be a left atrium, smooth-walled, with no pectinate muscles spilling outside the confines of the appendage, consistent with a morphologic left atrium. Here we can see the atrial septal defect that we noted from the right before. And here is the left atrial appendage. And here's the mouth of the left atrial appendage. And you can see all the pectinate muscles of the left atrial appendage are confined within the appendage itself, consistent with the morphologic left atrium. Now here we come to another atrioventricular valve. This valve has two leaflets without any septal connections, consistent with a morphologic mitral valve. And then this ventricle has fine crisscross trabeculations consistent with a morphologic left ventricle. When we turn our attention to the outflow tract of this ventricle, we can see there is no other egress except this ventricular septal defect that we have seen before. And when we go back to the right heart, then we see the common arterial trunk once again. And what's interesting to note is that the common arterial trunk seems to arise mostly from this morphologic right ventricle. And when we're dealing with common arterial trunk, it's important that we always mention, one, if it's aortic or pulmonary dominant, and in this case, since there's near interruption or significant hypoplasia, this is a pulmonary dominant common arterial trunk, that we describe how the branch pulmonary arteries arise from the common arterial trunk, and also describe the relative position of the common arterial trunk to either ventricle. So a heart with common arterial trunk with pulmonary dominance due to transverse arch hypoplasia and branch pulmonary arteries that arise from separate orifices from the posterior aspect of the common arterial trunk.